We have Ryan Brewster joining us online, and we have Alyssa Abo and Bronwyn Harris joining us here in person. And we're going to be discussing a challenge that we see all the time, especially as Impact One advising pediatric startups in the AI space and understanding where the shortcomings are, where the benefits are, and how to navigate that space. So I wanted to start by having all of our panelists introduce themselves and their background, and then we can go from there.
Wonderful. All right. My name is Bronwyn Harris. I am a pediatric cardiologist. I did all of my training, my peds residency and cardiology fellowship here at Stanford. I did the Stanford Biodesign program, and from that program ended up doing a startup company in the pediatric space. So a pediatric asthma tool, was not really using AI at that time, did like a little machine learning. This was about 10 years ago. Ultimately sold that company, spent 3 years at Apple, and have been continuing to work in the digital health space since then.
Hi, everyone. I'm Alyssa Abo. I'm a pediatric emergency physician. I actually went into medicine through engineering school, so I've always been a little bit of a health tech nerd. I was like that as a kid, so this is nothing new for me. And then I would say, being an ER doc, I've always been a bit of an adrenaline junkie, and now I spend a lot of time working with startups, so it's a different kind of adrenaline, but fun nonetheless. I wear a few different hats, from advisor to investor, currently working for a startup here in the Bay Area, and just really thrilled to be a part of this morning. So thanks.
Hey everyone, I'm trying to not get distracted by my giant head, but it's wonderful to be here this morning, calling in from Boston. I'm a pediatrician. I just finished residency at Boston Children's Hospital, but went to medical school at Stanford. I will actually be returning for my NICU fellowship in July. But my work really focuses on building, scaling, and evaluating technology-enabled models of care. So how do we take these wearables, monitoring tools, and devices and implement them into coherent clinical workflows, really leveraging the opportunities afforded by technology to expand access to care. This year, I am a research and innovation fellow with a group called Ariadne Labs, which does health systems innovation. And our particular crusade is how do we operationalize a pediatric hospital at home? Again, very grateful to be here, excited to chat about our work.
Great, thank you, Ryan. I wanted to actually start with you and talk a little bit about your experience with looking at regulatory approvals for AI technologies in the pediatric space and how that's compared to the adult space and what you've learned from that work.
Yeah, absolutely. So I recently completed a study with Florence Bourgeois at Boston Children's Hospital, analyzing all of the AI ML enabled medical devices that were approved by the FDA over the past 20 plus years. I think there were close to 1,000. And the major take-home points from this cross-sectional study were that one, pediatric-specific technologies have lagged behind those in adults. We've seen this narrative before with medical devices, but this is really showing that that pattern has extended to our latest advances of AI. And then when we look at just devices, AI, ML-enabled devices approved for pediatrics, less than 20%, I think, explicitly documented that children were even involved in the testing and validation of those databases. And so in thinking about the higher order messaging from this work, it really exposes the challenges with the current regulatory environment to ensure safety and equitable performance of these tools in children, particularly when they're not even being involved in the development of these devices. Certainly, there is a significant onus on the developers themselves to be ensuring that their data sets are representative of the intended populations, particularly when it involves kids. And then from a clinical perspective, it makes it very hard for us at the point of care to be able to make informed decisions on behalf of our patients when there is a lack of transparency with the data sets that are actually being used to build these models.
Can I just add on to that for a sec? So Ryan, I love everything you're saying, and shout out to Boston because I did my fellowship there with the Bourgeois sisters. So you're really dating me a little bit, but yes, they really are the best. But just to Ryan's point, like we're actually seeing this across the ecosystem. So from wearables, which Bronwyn is resident expert, so I'll defer that part to her. But from startups to the larger companies, one of my areas of focus is point of care ultrasound. So Ryan was mentioning the point of care. And the last ACEP, so the emergency conference I went to, they're like, come see like all this new tech and look at all this AI. And my question was, okay, so like what can we use in kids? And there was nothing, like literally nothing. And these are large organizations with enormous amounts of funds to actually be able to do it, and they're not. So then the question is like, why not? And how can we encourage them and motivate them to build these technologies and tools that we are using in the emergency department and in the ICU and all across medicine, but they're really not available for pediatrics.
Such a great topic and point, and I think it's just yet another new area where pediatrics could benefit, but they're not as much as they should yet. And I think, a lot of it comes down to simple business model. Companies, there are nonprofits too, but even though, you have the market, they look at, well, we need a whole different data set from the pediatric side. And often, we know adolescent is not the same as a toddler and, all of that. So there's a lot of additional work to go into pediatrics, and often it's an afterthought. It's not a thought. Maybe it's actually a decision of that doesn't make sense for us. And so, how do we turn the table, whether it is, having data sets that are available, because I do think it is a bit different. Like you look at a medication, you have to do a trial, like you need a child that needs to take a med to really study. And yes, you can, model and try to have smaller studies, but in AI, I think there is an opportunity to, maybe it doesn't need to be as hard to expand into peds, but we're not there yet. Yeah. But we should be. We should get there.
And it's even things that are simple, but then as complicated as heart rate, right? Adults, if your heart rate's 150, 160, that's just bad, right? But in pediatrics, you're like, okay, depending on your age, great, that's totally normal. And so I think it just, from a very early on, it's like you take these sorts of things, it's like, oh, well, vital signs, I can't even get that right. Forget, I'm not even going to even go there for the more complex things.
Yeah, and I think a great example of that, not AI related, but Fitbit turns off heart rate for under 13 years of age. I've asked many people that work there. Everyone sort of said, that's not my decision, and I don't, if anyone in this room can tell me why. I would love for that not to be the case. The Apple Watch does go lower, although I actually can't get a straight answer of what age do they stop it. So, there's no reason that you need to turn it off below that, right? It's not giving, now it makes sense that they've turned alerts off. That I think makes perfect sense, but why not measure the heart rate?
These are all great questions, and I think the limited data set, it's kind of a double hit for pediatrics where you're looking at small markets and now less data available. One of the things that obviously comes to mind is how can you leverage combining data sets, collaboration across different children's hospitals. Is that a factor that you've encountered, Alyssa, that with real world evidence and how we can use that in AI?
So I'm a total data junkie, which is why they know that, you get me started on data, but I will try to keep it short. I will just say, the data is king, data is queen, whatever it might be. Data really is a backbone of all things. And I think data oftentimes is not as sexy as the devices themselves, but nonetheless, we need data to build better devices. And then the devices we build oftentimes generate even more data. And I think we sometimes forget, we don't have a data problem. We have a data silo problem or a data access problem. And so how can we overcome that? So one of the first startups I worked for was a real world data company, and it was all around real world data and how to access that. And it made me more well-versed in trusted data environments and federated models and what that looks like. And I would say it is encouraging to see that there are more pediatric data sets coming about. But when it comes to actual pediatric real world data that's accessible, that's collaborative, we're still not there yet. And I'm hoping that, in the next few years, people in this room, myself included, can be a part of actually building that. I know a colleague at AWS from a corporate standpoint, he's also really trying to push that forward. But right, Kunj, to your point, I think until we're able to really access large amounts of data that are truly longitudinal, that, even start in utero all the way through adulthood, we're just kind of picking little pieces of it and doing the best we can with what we have.
And I think there are absolutely examples where the children's hospitals have coordinated from, pediatric oncology and then pediatric heart failure, very, very small numbers, but there's like Action Network. Now, I do not know of that there's, compiling data sets specifically for use in this case, but they could. And again, the sort of pediatric and children's hospitals working together, that absolutely happens. And so I think there's an opportunity there that should jump on.
You're totally right. And, as you're saying that, like CBTN, which is Brain Tumor Network, so collaborative among the children's hospitals, and AWS is involved in housing the data. And I don't work for AWS or anything like that. I just happen to know, like, some of the pediatric initiatives that they have. But you're right, it's usually very disease specific, and then sometimes encouraged or motivated by the organizations that are focused on that disease type. So there is some of that. And sometimes that can be international as well, which is, even better. But it's all still seemingly to me like these disparate data sets. And it's like, really, how can we band together and do better?
Think about it from the startup perspective as you're coming in first looking at a clinical need and thinking about how that clinical need can be solved with AI. Obviously, they're going to need to partner with these different healthcare institutions. And one of the things I see as often a challenge is just getting that trust and partnership with an institution early on. Ryan, from your experience, do you have any advice for that approach?
Yeah, that's tough. And I think the need for these multilateral partnerships cannot be overstated. Operating primarily from an academic medical center, it can feel very frustrating that oftentimes we're just dealing with the consequences of bad tech rather than co-developing these tools and making sure there's seamless integration into existing workflows. And I feel like it oftentimes starts, as you mentioned, with identifying a good need that has a legitimate burden on the health system, oftentimes boiling down to one of our kind of quadruple aims. Is it affecting health outcomes, access to care, cost of care, or provider experience? And so I think having an understanding of what institutional priorities are and the drivers of the bottom line helps to create that alignment so that you're actually bringing value to the hospital and partnership. I think what's also challenging for any innovation in healthcare specifically is that your customers are not only your users. And I think those things can sometimes be conflated. You're not necessarily selling to a physician or a nurse. And likewise, the value analysis committee is not always the one who's going to be deploying your device in practice. So I think differentiating those two, they each play a very instrumental role in the ultimate adoption of a technology. And trying to identify who those key opinion leaders are in the uptake of tools is really essential from a strategic standpoint to build those collaborations with hospitals and health systems.
Thanks, Ryan. And Bronwyn, as Ryan mentioned, there's obviously different people that are using your device and different kinds of tools or problems that AI can solve. And how do you kind of approach that as you're integrating AI into new technologies?
Yeah, I think first of all, great that everyone's saying starting with the need, because think of that. Sometimes AI is actually not the solution, so it shouldn't always be that. So just putting that forward. But then in terms of implementation, I think one, it varies. So just we're saying AI, and this is not going to be a lecture of what exactly is AI, and I'm not the one to give that, even if it was. But there's so many different things, right? I mean, there's supportive. There's hey, I want to summarize the latest literature, or I want to take educational content that I have, translate it, put it in different, formats, have a fun one for a, younger kid, have a more serious for a teenager. So there's, supplemental ones where it's not at all that. Then there's diagnostic, there's treatment. So we're grouping it together, but, just to be clear, right, some things are very, very different. And I think then, adoption and implementation is different with all of that. But saying on a more, heavy non-supplemental one, first of all, adoption's tough in medicine. That's, I feel like, not exactly our strength of something new, changing guidelines, changing anything. So that's just hard in general. I do think for AI, it used to be really big headwinds. And I think now that's not the case. And I actually really like the AMA has put out now 2 years in a row a survey where they survey physicians. Only 1,000, which I wish.
I know, I was
AMA.
looking at it this
I
morning, I
wish.
thought the
I
same
wish it
thing.
could be. I think they should be able to get 10,000. But still, I think a really interesting. So the data from 2023 was only about a third of physicians said they were using some sort of AI regularly in their practice, and then 1 year later, it's 2/3. So I think the whole AI, while that used to be negative or ooh, that's scary, and they also did survey, kind of, are you more excited, your excitement versus hesitancy. And that last year, there's only about a quarter of physicians who are more hesitant than excited or more worried than excited. So I actually think that isn't there. Now we're a medical community, right? There's always going to be, I think, that quarter that are more hesitant. But I think one other thing, actually, that excitement, there's a little concern I have of people not understanding AI, this sort of black box that same as, a new med that may have miraculous results, there's still certain population that it shouldn't be used in, or, side effects you need to watch out for. I think there's similar that AI to a lot of people exciting and they're not quite understanding, well, okay, what is it that you need to double check? Recently at the HIMSS conference, and of course the scribes or the, big thing they're talking about implementation of that. One of the concerns I heard was doctors taking 100% of the note, not making any changes. So organizations talking about how they're actually reaching out to those individuals. Now they don't know what's that right percentage, really unclear. Should you be, changing at least 10%, but 100% right? Did it get everything right? Probably not. And so are you actually checking it? So I think that is actually something we need to make sure, do physicians, when they are using these tools, actually understand the limitations?
So much good stuff there. It's funny. A few years ago, I was a Cerner physician advocate. This is before Cerner and Oracle even got together, maybe 2017, let's say. And we were at the conference, and they said, oh, we have this great idea. We're going to have something listening in the room while people are talking. And everyone was like, no, that will never work, right? And it's just been so interesting to see how medicine is historically risk averse, and a lot of times I think for very good reason, and really resistant to change, to actually I think right now being a little bit desperate for change. And it's funny, I was looking at the AMA survey also, and to Daniel's point earlier, they talk a lot about the augmented intelligence. And I think a lot of us keep saying, AI is not going to replace us, we can relax, but if you don't use it, then, people who do use it might replace us. So anyway, needless to say, when I was looking at the results of that, some of the other two things that really struck me were, one, there's a really big push for the administrative side, like decreasing the burden and trying to help, offset some of the burnout, I think is huge. And I think people look at that as a little bit less risky, if you will. But then the diagnostic part, can you use AI to augment your intelligence when you're thinking about a differential diagnosis, right? And we know that our patients are using ChatGPT and Google, so how can we also use these tools to our advantage to make sure we're really doing right by our patients, which at the end of the day, I think is always top of mind.
Yeah, and the only other wrinkle I would add is, this is a story old as time when there's very rapid adoption of any new innovation. We have to question who is being left behind as part of that. And we've already demonstrated that a lot of these models, generative AI especially, are reifying biases and prejudices that have created structural inequities on the basis of language, on the basis of race, geography, et cetera. I know Naimisha's in the crowd. We're doing a lot of research to understand how large language models can be leveraged for patients who speak languages other than English. And we're seeing disparities for languages of lesser diffusion that just don't have the same digital footprints to train these models. So are we actually worsening these inequities rather than realizing the real promise to increase access to care and outcomes?
I think these are all great points. And one thing I think about some more with pediatrics is that your user varies. It's the child and the parent. And how do you approach that component? Because the adoption of AI, adoption of wearables, all of those things are different in that pediatric population. And how do you build that equity?
I think so again, depends on the need and how the user varies. I think the fact of, say, using a different tone for, a child and even a different age child versus a parent, that I think is something where AI can do very well. And you're not necessarily worried, right? I mean, maybe you have very specific education and you're feeding that in directly. So you're not really worried about that specifically changing. So I think there are some things where, gosh, that is right in the sweet spot of, hey, I don't want to write, 5 different versions of the content that I have based on the age. And I can, outsource that into AI, chat bot-esque sort of stuff of, taking the same information but making it more conversational. I think those are great opportunities. At HIMSS, there was a demo from Samsung Medical Center and their, robots and actually interacting with hospitalized children and, making the conversation, whether it's like pre-procedure and having that interaction. So I think some of those things actually, it really depends on what it is, but specifically in that sweet spot and having it, a different, and then taking that same information, but for a parent, having that different, I think that's great. And that's something, the adult side probably isn't utilizing it much, although you still have caregiver roles versus, someone being cared for.
Excellent points. I think a lot about how technology can close the healthcare gaps. And by and large, I think parents want to be informed. So how can we leverage that, right? The idea that we have these technologies, that it can help families be informed, and then also bring more technology to not only rural parts of our country or places where there are healthcare gaps, but even globally, like really start to sort of tease that out. And then people have been talking about trust this morning, and I think there is trust. I mean, it might be, sometimes a little bit chipped away out, but I still think that trust between the clinicians and the patients is fundamental to medicine. And so I think if we say, hey, this technology can help you better care for your child, then immediately it becomes something that they would consider as opposed to having to figure it out on their own, which nowadays there's so much tech out there that they can buy that's really for adults, right? Like not even pediatric specific, but it's like, oh, well, I'd like to know, how my child's sleeping. It might be very simple, but they don't really have any guidance on where to go. And then to me, I see a lot of value also for complex patients, like medically complex patients. Those families, I just think, are angels and they're knowledgeable. And if there are ways that we can help them better take care of their children at home, like this is already such an educated population, especially medically. I can't help but wonder, like, you have a VP shunt. We have technology that can help you figure out if your shunt is malfunctioning or your child is, unfortunately has a GI bug and that's why they're vomiting, right? But like we can help them not have to drive 3 hours to the pediatric hospital and let them stay home. And so it's a little bit of a long-winded answer to your question, but I think at the end of the day, parents, just like the people caring for kids, want what's best for them. And how can we help facilitate that and really be at the forefront of that so we can take some of the guesswork out?
The work you've been doing for hospital at home, I'm sure that this has a large component there in figuring out when is the right time to bring someone into the hospital versus not, and that finding that balance ethically and from a diagnostic perspective.
Yeah, absolutely. And I think one of the additional challenges in pediatrics, in addition beyond the ones that we've already talked about, is that a lot of our practice is not necessarily dictated by objective metrics, in large part due to the lack of robust primary research in the pediatric population. And so when you're making a decision to triage a patient to come into the emergency department, go to urgent care, it's safe to stay home. A lot of it comes down to your clinical assessment of the patient, of course, but also, the comfortability of the family. I have spent time in London with a pediatric home hospital program, and we were visiting these families for kids who had bronchiolitis, the most common reason for hospitalization in kids, and children are visibly retracting, they have desaturations in their oxygen levels, they're receiving supplemental oxygen, and the families are fine. Whereas in the United States, that child would have been admitted upstairs and probably had a 3 to 4 day hospital stay. And so despite the same clinical presentation, how families, how physicians handle that information can vary substantially. And so I think this is where there needs to be not only a human in the loop, but also, a family caregiver in the loop to the extent that these models will provide an output that ultimately needs to be placed in the context of the values and preferences of the families that you're serving. And this exists for all patient populations, but I think especially so in pediatrics, where there is that more complex dynamic with the patient, the caregiver, and the provider.
Makes a lot of sense. There's so many components to consider. I know we're kind of getting towards the end, but I wanted to kind of first ask all of you just what advice you have for founders that are looking to either integrate AI into the technology they already have developed, or if they're looking at needs where it seems like that is the solution.
We've sort of been hitting on this, but I would tell any startup, if you're working in this clinical space, building AI into an important need, is that you need clinicians involved in, ideally, and I know easier said than done, but a health system that you're building somewhat with or you're working with early on. If you're building this full solution and then coming and trying to sell it without having that, and I think in particular with AI where you're needing a data set, presumably, and again, AI is many, many different things, but so trying to figure out now, and again, you can't be everything, like to every health system. It doesn't then keep going that each health system, you're like, oh yeah, I'm gonna, custom build this for you. No, but when you're starting, how do you find that partner and making sure that you're getting that need right and that you're addressing it in the right way?
I think that's paramount, the connections with the clinicians and making sure you're solving a problem. So let me try to layer onto that. But before I do, I just want to say thank you for having me be a part of this. I'm super humbled to be here, to be on the same stage as Daniel. Like, I'm still a little bit pinching myself, so I'm sure I'll come down off this cloud in a few days. But advice to founders, I think, is to think a few steps ahead and think in multiple dimensions. And what I mean by that is I often hear like, oh, we have this great business plan, but maybe the regulatory plan is secondary or the clinical plan is secondary. And so I think it's really hard to be a founder, and I tip my hat off to those of you in the room who are, but thinking about how the AI and how it layers into your potential device or if it's standalone, but really thinking about the different facets of that and then the 2 steps ahead. Okay, so if it's a device and it generates all this data, like what am I going to do with that? Where am I going to store it? How am I going to use it? Same thing with the partners. If you're working together, you're collaborating, like, so then what? What happens next? And I think many of you are probably doing that far better than I could ever, but that would be my best advice.
Yeah, and I couldn't agree more with what has been shared. And I think to build on that a little bit, there's this like with any product progression, there's this like unsexy middle where you've gotten through the R&D, you've done the initial validation, but then you actually have to traverse that last mile of making sure that it's compatible with workflows and clinicians like it and it's intuitive and it's frustrating and slow and oftentimes happens behind the scenes. But in my experience, those the teams that put in that work to understand how it's going to fit within what is a really complex ecosystem in a healthcare environment are the ones that end up being successful and having traction. Speaking as a clinician, you can dangle the most advanced tool in front of me, but if it makes me stay 5 minutes longer past my lunchtime, then the likelihood that I'll actually use it is challenged. And so I think just being mindful of those realities and how messy it can be is just super important, and making sure your solutions accommodate those.
Thank you so much for all of your insights. And I know that this is a topic that we could talk about for a really long time, and it continues to be case specific, but it was great to have everyone's insights.
Thanks.
Thank you, everyone.